Good morning, everyone. I'm Dr. Quilici, and I'm going to present today our healthcare system effort to pinpoint the value of robotic surgery, or at least robotic-assisted technique in intra-abdominal procedure. We have nothing to disclose. So this analysis was really, like I said, an effort for us to pinpoint the value of robotic-assisted procedure and to really try to identify where our surgical healthcare dollar was being spent. As most of you have seen and probably experienced in your healthcare system, the issue of cost with robotic surgery has become very sensitive. So this study was structured to match clinical outcome versus performance cost in 3 surgical techniques: open, laparoscopic, robotic-assisted, in 5 core or high-volume intra-abdominal procedure performed on an elective basis during a 24-month period pre-COVID ending on December 31st, 2019. We use validated analytic with normalized cost. Originally, this data was extracted out of 54 acute care center or hospital. We eventually segregated or extracted 11 of them that were not on the same IT platform at the time of this analysis. To give you an idea of the sample we came up with 34,993 patients or procedure. The only procedure that did not have elective case, of course, is appendectomies. But as you can see, this gives you a breakdown of the 5 high-volume procedures we analyzed with the penetration with robotic-assisted technique. Hysterectomy came first, then inguinal hernias, followed by colectomies, and then cholecystectomies. The outcome were analyzed. We've had actually multiple set and indices to analyze to kind of try to see, to compare the outcome for each technique. The first one we did analyze is operating time. Well, this tells a story that we all expected. It takes longer to basically perform a robotic-assisted procedure versus traditional standard technique. It goes from 57-minute differential with colectomy to about 38 minutes with inguinal hernias, and this is again all across our system. When we actually analyze the clinical outcome of this procedure, the conclusion was reached pretty quickly that all those techniques serviced similar elective patient population, and pretty much the outcome of all 3 techniques were the outcome for the inpatient cohort for laparoscopic and robotic-assisted technique were very similar. We noted that there is a very slight decrease in LOS for robotic-assisted colectomy, but this was traced as the majority of them having an ERAS protocol activated at the time of this procedure, when the laparoscopic version didn't have it. And actually, we noted now the reverse with laparoscopic hysterectomies, where they are actually slight advantages for the length of stay. So to make long story short, the clinical outcome on a value-based perspective were pretty similar for the laparoscopic and the robotic-assisted technique. So then we went to cost, to measure cost. Well, we use normalized cost. We use also standard healthcare industry accounting terms, direct cost per case for our audience or provider, and to kind of refresh all those costs that are being used and defined. This is pretty much the true cost of performing those procedures. Indirect cost per case are actually what we call the corporate overhead or the medical center overhead that is tagged onto those cases. Total cost per case is direct plus indirect cost per case. And the net margin per case is actually what gives you a kind of a snapshot of the profitability of those procedures, or loss actually of those procedures. So when you look at what we have uncovered as far as cost for direct cost, pretty much we index all our costs to what we call average Medicare reimbursement to give you a sense of the profitability or loss of those procedures. And you can see pretty quickly that particularly for cholecystectomy and inguinal hernias, the robotic-assisted technique are more than twice more expensive to perform than their laparoscopic counterpart. That delta is a little less significant for colectomies and hysterectomy, but that data also alarmed our financial team when we really realized that the cost differential was really pretty significant. So when now you go and you analyze the total cost per case, which is next, then the fiscal profile of all those procedures deteriorate pretty quickly. What surprised us actually when we looked at this is that even some of the standard laparoscopic procedure, which traditionally have been really done on a profitable basis, really outperform at a loss when you compare them to Medicare reimbursement. When you look now at what we call the global net margin analysis, which is a number we use very frequently to kind of assess the fiscal viability of our service line, where we aggregate all the procedure together, we combine them, and then we pretty much, in this case, segregate them in the three techniques, laparoscopic, open, and robotic. Well, you can see pretty quickly that we actually still are turning a profit for intra-abdominal procedure, about 30% for laparoscopic procedure, open procedure, that dropped to about 16%, and then for robotic, we're now generating a loss of minus 3%. And actually, when we look at this, our financial analysts were very quick to point out that that loss should be even more pronounced. The only reason why it's not is because most of the case, 59% of them, are performed in commercial or patient with commercial insurance, which historically have a better payment structure than the governmental payers. Now, when you look and you take that data and you now break it down to net margin analysis by payer, by procedure, well, then we have about 3 data points that really alarmed us. Is that if you look actually at this data set, you'll see that hysterectomy is actually the only procedure where robotic-assisted technique are turning up a profit of about 6%. When you look now at really cholecystectomy and inguinal hernia repair, suddenly we generate a significant loss on both of those procedures. When we try to figure out where this cost came from, where pretty much the breakdown of robotic-assisted procedure was pretty simple to come up. We pretty much 60% of the costing, 67% of the cost increase is associated with labor, general supply, and OR time. 33% of the cost increase is related to platform-specific costs, such as equipment, service contract, maintenance, etc. What I want to point out is actually that kind of amortization process has been done also in this analysis for the laparoscopic procedure. So we are basically comparing really orange to orange and apple to apple, as the same process amortizing the investment expense has been done for our EndoSuite and laparoscopic platform. So to make a long story short, and to conclude this analysis, and I'm going to precise again and underline this, this is a value-based analysis, which is not a newer type of analysis to see really the true clinical values of new technology. Robotic-assisted technique produce similar clinical outcome and are as safe and as traditional surgical approach, but they are performed at a much higher performance cost. The ROI, or the so-called return on investment calculation for surgical robotic technology, needs to be adjusted. In our system, it has been really undervalued dramatically. So we are recalculated those return on investment calculation for the robotic platform. Routine use of inguinal hernia repair and cholecystectomy is simply not supported with this analysis. Oh, I'm sorry, that's one thing I forgot to turn off. Robotic-assisted colectomy and hysterectomy should be used routinely by surgeons demonstrating acceptable cost per case profile. And again, what is clear with this analysis is that laparoscopic cholecystectomy remain the optimal surgical technique for patients requiring a cholecystectomy. Thank you.